You can move your transducer just a tiny amount and change the amount of IMT thickness considerably from, you know, the second to the fourth quintile or something.
That's
I think
a
it has-
stenographer problem.
No, I don't care.
In terms of the transducer movement.
No, I'm talking about measuring it manually. Measuring the IMT manually.
So the
Versus-
cursor, you could just move the cursor slightly higher and or choose different sections and come with different readings. Different numbers.
Versus taking a few centimeters of the distal common carotid artery and measuring the average over that length.
With an automated method.
No,
Yeah,
he's saying the
semi-
menu.
a
It doesn't even really
semi-automated.
matter, right? Because even if an automated method, you still have someone who overreads it and adjusts it for what they think are mistakes in the automated placement of the line.
Well, there are several methods to do the reading itself. The completely automated, which I think very few people use, because you cannot really interpret artifact. So most of it is an overridden semi-automatic method. And so the reader does contribute some
Well,
variability.
then there is a contribution of variability
Oh,
because
yeah.
the reader, there is a reader.
Small, very, very small.
Right, but that's the crux of the problem, right? There may be a small variability, but you don't need you need a 5-pixel change to change quintile or quartile.
Right,
That's not,
that's right.
right? So
Yeah.
that's the problem with this measurement. The fundamental problem is we're saying that a millimeter is bad, 0.8 millimeters isn't bad, and 1.2 millimeters is really bad.
You're talking about the variability?
No, I'm just talking about the difference you need to make in a measurement to actually change someone from, you're fine, I'll see you in 5 years, to, oh my God, you need drugs.
He's talking about the pixels in the measurement,
And
so
so the reader can make a small
Right.
change when they're
Well, back to-
overreading and
so
then make
back-
a big difference.
what Gene said about total automated is not being, he said, it is not
Total
capable of
automated has the problem of not being able to interpret artifacts.
artifacts. Okay, so let's move on to physiologic variations. Is it really so you mentioned the anatomy, the way that the measurement is, and we know Kathleen was questioning in our meeting about ASC. Do you have a comment? Please
Yeah.
go ahead.
I have two comments. One, I don't think intimal medial thickening adds too much. And I'm not getting now into the risk factor profile. Let's get out. Just get into the carotid artery. We have 6,000 people where we have done intimal medial thickening and plaque with 3-dimensional ultrasound. And I can tell you, in the Chicago area to start with, 70% of people have already a plaque of at least 1 millimeter if you use 3-dimensional ultrasound. So in a way, this wipes out completely whether you talk about intimal thickening or not, because you already have plaques in the majority of people who are over age of 55 and at least one risk factor. If you use a technique which is 3-dimensional.
So they have plaque? You
Yeah.
said plaque and
Plaque,
1 millimeter?
plaque. And I'm not talking about now, actually, Erling knows the data too.
This is HRP trial.
It's the HRP trial, which I will say a word later. So what is important here is maybe 3D is not feasible and intimal medial thickening is feasible, but I'm not discussing that. I'm just discussing the issue.
So you're saying that the
Right.
extent of the problem is very, very
It's a burden of disease, and I can tell you it's very diffuse all over. But there's a second issue, and that is Erling's comment. Erling said that the fact that the intimal medial thickening, you have some degree of fat there and so forth is reversible. My question, Erling, is that the fact that something is reversible to me is much more important to look at the burden of disease and the risk, how high it is, and then act, than just by something that you see is very small and can be reversible. So I don't see that's an argument. If I understood you properly.
Yeah, I just say maybe if you want to monitor the disease and monitor your treatment, whether it's effective on the vessel wall.
Yeah, I'm sorry. Maybe I didn't
That's a good
understand.
point.
I agree with you that plaque is I think, much stronger predictor than
Yeah.
IMT.
Well, this is fascinating. So you're saying in your studies, about 50 or so people have more than 1 millimeter, and therefore
No, have 1 millimeter or more. That's
1
what I'm
millimeter or more.
saying.
And you
And
measure
you scan from the top to the bottom, anterior, posterior, and side to side. This is a 3-dimensional ultrasound.
and you actually create 3D rendering
Yes,
volume, so
we
you
do.
can actually.
You do.
This is fascinating. So
But the prevalence of disease depends on your definition. 1 millimeter definition is not
Well, I
If you
will.
make it 1.5 or 2 millimeter, then you will find that your bevel is going to go
No,
down.
it's a focal, I'm sorry to tell you, it's a focal plaque of 1 millimeter or more. And most of it is more than 1 millimeter, that is focal. Be sure that we understand what a plaque is.
So it's not a continuum,
It's
it's
not
not
a
a continuum that.
And this is an issue that is being analyzed by Silerson now. And actually, we have intimal medial thickening in the 6,000 people too. I want to point out that in a kind of early kind of structure that you see that there is so much variability, when in fact you might miss that you have an elephant in front of you. And maybe we should go up to the elephant rather than going around into just mentioning again. It's a comment. We don't, actually, we have a lot of information which we are not able to display here for the sake of that has not been published, but I'm just making a general comment.
That's a very important comment. If you really find plaque and it's more than 1 millimeter and it's focal, it's not a continuum that you call it IMT.
That's not really correct. It's not uncommon to find diffuse intermedial thickening in the common carotid artery,
Okay.
or in the bifurcation, or in the internal carotid artery. And that can be due to medial hypertrophy, it can be due to diffuse intimal thickening, hyperplasia. Most pathologists would not call that a plaque.
But what his point is
Very
one
good.
focal. He says
It's
focal thickening,
He's
more
what
than
I'm
1
talking about.
millimeter. That's, so Erling, you comment here.
Yeah, but it's focused into the Mannheim classification that is used.
Sure.
Well, the Mannheim classification separates two processes, that IMT is independent and
Yep.
separate from plaque.
Yes,
And
sir.
that's not true.
Okay, we can argue on
No
that.
way.
I think they are very
It's
different.
been validated.
I think they are very
for both
different.
They are
normal
completely different.
It's
and
a
pathology.
diffuse disease and a local disease, and they look very, you don't have a plaque, you may have thickening, diffusing, but a plaque is composed of more than media and intimal thickening and a few foam cells. It also contains more inflammation, lipid accumulation, necrosis, calcification, hip plaque. You don't see that in diffusing.
Not all plaques contain them.
No, I agree on that.
I have one
But
more
the
question.
point-
The 3D ultrasound resolution, the 2D, that the best we have been able to get to is 0.1 millimeter resolution. And I know that the resolution of 3D ultrasound is far inferior to that of 2D.
I don't think so. This is now being analyzed, but I can tell you the following, that the amount of disease that we see with 3D is much more than with the conventional ultrasound that is being done. What we have not done is a comparison study, but it is obvious. You scan much more of a surface than you do with the other. In other words, you don't miss. About the resolution is a different issue, but certainly the surface that you scan is much broader than.
So this is the same, carotid ultrasound
Yeah.
that you start from bottom and you swoop all the way up, and
That's
then
the
it's
issue.
software.
The issue is that is the extent of the surface that you are analyzing. It tells you, we have not done the comparison, that 3D ultrasound is much more providing of information than the usual ultrasound that we have. I cannot go into, what is the
Resolution of physics.
but certainly, what is important, this is a diffuse disease, I have to tell you, this is what we learn with HRT studies all over. It depends where you pick it up, you can already predict that the other artery is getting there sooner or later. So therefore, I think,
Well, that's fascinating, because
Can
that's
it be
what,
used as a screen today?
well, I will talk in a moment, because I only wanted to make a comment, and that is, we are going through a torture with intimal medial thickening, and I'm not entirely sure it's necessary. That's my only comment.
okay. Well, what I get here is that once we have a plaque called 1 millimeter or more, your definition of plaque is not 1 millimeter
It has to be focal and
Focal.
more than,
It's
it has to be
focal.
focal.
and more than 1 millimeter.
No, not more than 1. 1 millimeter is very little, I
Okay,
think.
so 1.5,
1.5.
1.5.
That's the Mannheim consensus too.
okay?
Yeah, well, actually, the incidence is very high for more than 1 millimeter. We just
So you're saying risk in it, okay?
Are we putting all plaques in the same risk assessment, regardless of echogenicity? Or
Well, that's a
is there going to be a
different-
discussion between?
That's one layer after that. The first
Okay.
cut
Well,
is,
I thought I was hearing a movement to, the fact that they have plaque, no plaque, puts them in the highest risk category,
that's one.
independent
then
of
you can go-
echogenicity.
Yes, there is quite a few, there are quite a few publications on adding, but that would be next level. But
CIMT is much more a reflection of hemodynamics, hypertension, and it's really, and plaque is atherosclerosis.
That's right, that's what Ernie was talking
Yeah, and I
about,
think
yeah.
we should think about
Okay,
it.
that's what he was talking about too.
Yeah.
So you have one cut, you've got the plaque, and plaque is more than 1 millimeter according to HRP criteria, and 1.5, and then after that, you'll be able, so what Ernie says is you would, by measuring IMT along with that plaque, is you'll be able to do repeat measurement. Now, what do you think as far as repeat measurement? 6 months, a year, 2 years? Any idea? This is, of course, this is not evidence-based because we're still in the.
Well, it would seem obvious to me that if you had plaque, that you crested your, whatever the thickness was, and we decided when treatment would begin, you would never need another measurement, because, and by the way, this is sort of the problem with the whole thing, right? Why would you ever need a repeat measurement in someone in whom you're going to apply maximal medical therapy?
Well, you may not.
So
Yeah,
my
yeah.
answer to you would be, if you crested that limit, you don't need it ever again, and then the reproducibility issue.
But there,
would probably stay
I think there is a problem with maximum is maximum in our textbook, but maximum may not be in their lifestyle. You know, the compliance of therapy. You could see most people were not, you know.
We did a variety of cases in which Dr. Fuster's group was doing PET scanning, looking at diffuse atherosclerosis. And we were basically using LDL particle number as a criteria for maximum treatment. And we found that the LDL did not matter. We had to get total cholesterols down to 105 to get particle numbers below 1,000. And then we could quench the PET scanning.
Yeah, but at what level wouldn't you give someone maximal therapy?
Well, yeah, but but in order to be maximally therapeutic, in a couple of these very advanced cases, we could not quench the radiation without giving them 4 drugs and getting the total cholesterol down to 105.
Yeah, but you're gonna have a really hard, I don't wanna, I wanna.
let me
think
turn the
time, but
discussion
we just
to
had
that. I
an
think you-
outcome trial now, so
I
maybe
think
the
Josh
secondary
brought a
risk
very
factor doesn't
important-
make a difference.
Very important. Let me stop the one-to-one, please. The point here is that you made a good point. You start, you measure, you are at high risk. Why do you need to do it again? Arby, why does he need to do it
Because you
again?
have to have some better way than looking at a blood test to judge the efficacy of your therapy.
But what is the result of doing that?
You change your therapy depending upon the results of the repeat test.
So then why are you starting non-maximal therapy at the first time?
Nobody's on maximal therapy.
Well,
We don't even know what that is.
It's very
Nobody's-
maximum
Nobody's on
definition.
maximal
What is the
therapy.
very?
Let's start there. It's impossible to start everybody on maximal therapy. Maximal therapy is multi-drug. Nobody starts with multi-drug. Nobody does.
And
You can talk about your own practice, but nobody does in practice. We've done these large trials. Pfizer's done huge studies. Nobody even gets LDLs to 100, much less 70 or 40 or plus niacin or plus fibrates.
But you're not, so if the goal is to make these things available, you're not gonna get there today, because you just heard, we were all here yesterday. We know that when you add a fibric acid derivative to a statin, it doesn't help.
And when you add niacin, it does help.
Well, not in outcome trials,
It
only
does in
in.
every outcome
Well-
study, name one that it failed.
Yeah. I think we have.
And when you add it on,
Yeah.
I can't actually
Yeah.
add an outcome trial where it's been
Hats,
done.
fats, arbiter,
Yeah.
halts.
Well, one thing.
Well, Arbor, that was not an outcome trial, that was a surrogate trial.
But it's,
That's the
reduction.
problem.
right.
That reduction makes
But
it
let's not be the inadequate current therapy issue, which is an issue. We're not going to stick, to this, level of available therapeutic modules forever. But the fundamental point is you can't start everybody at the very maximum at the very beginning for several reasons. And there is also components of non-pharmacologic lifestyle modification that would really matter when you are identified at very high risk and you continue to be a high risk versus you are identified high risk and you hope you responded as a patient. Okay, if a patient doesn't know a year later or 2 years later whether they're still, or they're progressing or they're stabilizing or they're regressing. So this is my point, and I'd like to know what Roger thinks, because this issue of reproducibility with CT is a major issue because of radiation. But with ultrasound, there is no radiation issue. So what do you think, Roger?
Well, I agree with Josh that, the reason we're doing the AIM high and the HPS2 Thrive is to really know for sure we thought, you know, by improving LDL particle size of the fibrate, you'd get a benefit, but 5 years, we didn't see that in Accord. So I understand, you know, this issue about looking at residual risk, but you know, I think for the most part, the evidence right now is with aggressive statin therapy, and you have to, you know, realize that that's, you know, probably what's going to happen if you have a high degree of
So,
of
can I,
atherosclerosis.
so Roger, you have a patient comes in, they're on statin, got their LDL down to whatever you thought was a great target. You found out at their follow-up visit they had a recurrent unstable engine event. So you see them again. Do you change their management?
In that case, we'll do it without as much evidence as we'd like.
Okay, but that's what I'm just saying, is so Harvey may be wrong. Harvey may be wrong that this is the way to assess residual risk, but we always have options for increasing therapy. And when we're presented with somebody who we perceive is failing traditional medical therapy, be it Harvey's method or an event, we have ways of increasing therapy. It could be fish oil, which probably works. We can argue whether GISI is definitive or not. We have exercise and lifestyle changes. I believe, I agree with you, we need to wait for AIM high, but the niacin preliminary data is pretty promising, unlike the fibrate preliminary data from Field, which already told us it didn't work, and I think Accord was a waste of time and money, but you could have argued we knew that answer a long time ago, and Accord was concordant with current trials, that we can always increase therapy if we perceive that there's a need. So Harvey's trying to find a perceived need before we find out the patient died or had another MI.
Before we go
But
to
more
Jeff,
important than that, I think the importance of repeating a test, and in this case, I would still stand on my previous statement that at least 3 years, if not more, for IMT. It's for the patient compliance. You know, if the patient sees that their, you know, another plaque has come up, or whatever was there has become worse, I think that actually pushes them towards better compliance. I think that's a utility.
We need that, we need data.
yeah, well, compliance,
More than anything else.
well, Matt published a few things, papers on compliance for CT, but 3 years, if you're talking about compliance, you see your patients every 6 months. Why 3 years?
But
Well, because it takes that long for changes, discernible changes. to
So
occur.
changes
That can
above
be
the
measured.
variability.
Correct.
By the way, you also run the risk, if you tell someone that despite the drugs and interventions you've made, they've gotten worse,
Uh-huh.
they throw their hands up and say, so why does it make a difference what I'm doing?
Well, that's.
It is, you know,
that's-
there are as many of those people as there are people who will be re-energized to their therapy.
That's the job of the physician to deal with that
No,
issue.
but
That's a
there are-
non-issue
Yeah.
But
job.
there are studies
I don't
addressing
think it's
that,
not.
that actually the patients become more.
Well, I think that's an
compliant
issue.
in the picture.
That's an issue. That's an issue of therapy, inadequate therapeutic tools that we have. You're saying, and that doesn't happen to everybody. It's probably 20-30% of the population who are getting aggressive treatment. According to our outcome studies, there are still, you know, having recurrent events. So what to do with them, how to deal with them. Therapeutic intervention, we have in fact in the shape book, we have a chapter for those people with other aspects that you can, education-wise, in case they have symptoms, how to treat their symptoms. These are people that we can do something really about their early intervention the moment they have symptoms. They don't go into, you know, late arrival to hospitals. They don't discount their prodromal syndrome. At least you can do something about those, because we still have 6 to 8 hours average national time for late arrival to hospitals after symptoms. If they knew that they were in your high risk and they're not responding, you have an opportunity to intervene with at the very latest stage, or we call it active prevention. So,
Tasneem, you mentioned 3 to 5 years. That seems a little bit short to me. Is there consensus that it can be done in that short time period with CIMT and get meaningful results?
Well, I think it depends on the reproducibility, which happens to be the coefficient of variation, whether you're looking at common carotid or you're looking at mean of the max of all 3 segments, is at or under 10%. For the common carotid artery, it's in the order of 3, absolute differences of 0.3 millimeters, absolute differences. So the variability is much stronger than that of CAC, and stronger than that of other imaging techniques.
What does this translate into initial results? Josh or Jeff?
What's the question?
The question is what's the minimum period of time you have to wait to get a meaningful change in an individual, not a group of patients? Tasneem says 3 to 5 years.
In carotid IMT?
Yeah.
Well, since I have major issues with reproducibility over time, I can't give you an answer, because I don't think it's at the point where it is that reproducible that you can assess change over time.
You're talking about common carotid.
Yeah, I'm talking about even firewall common carotid.
Jeff, let's go through your slides so we can hear your thoughts and then answer this. So,
All right, so at least with my talk, there's no scientific data to support any of
okay,
this. so-
this is your opinion. Okay? If you're a president of somewhere, we're not counting for that president.
So-
This is your personal opinion.
So these are the basic issues, we've been discussing them, accuracy and reproducibility. There's no recommended standardization on the method of carotid IMT for clinical trials. In fact, a lot of different methods are used in clinical trials. And there are too many clinicians doing this measurement without proper training or equipment and receiving the reimbursement for it. So we can have the next. So I'm going to address the issue of certification and accreditation, and I'm going to address these three things in the next 3 minutes. Go back one, please. Is there consensus among experts in INT certification and accreditation? Should reimbursement be tied to certification? And should IMT certification and accreditation come from a single organization or single standards? Next. So the first question is there consensus among experts in IMT certification and accreditation? And my answer is I doubt it, because if there was a consensus, then the clinical trials that we see, the 9,000 papers on carotid IMT, would all use the same technique and not a different technique. And in clinical practice, there's even more non-validated methods used, like pulling up a common carotid artery from one angle one time, a different angle the next time, and hand measuring the IMT difference. Next. So this paper was just published, and this is a very interesting paper for two reasons. The first is that this showed that the only cardiovascular risk factor that had an impact on carotid IMT was the latitude at which the people lived in. So the higher the latitude, Finland, the greater the IMT thickness, the lower the latitude, the less the IMT thickness, and correcting for all other cardiovascular risk factors, this held up. So take a look at this paper. But for our purposes, this is the technique that was used. The far walls of the left and right common carotid bifurcation and internal carotid were visualized in the anterior, lateral, and posterior projections and recorded on videotape. And then it was reviewed in a centralized laboratory, which I think is imperative for reproducibility, and dedicated software. So the software is probably different. The approach is different. You can change your IMT if you go posterior to the sternocleidomastoid, if you go anterior, and it's different whether you're in the common carotid, the bifurcation, or the internal. Next.
Okay, we're going to come back to this slide. I haven't seen this study. Valentin also wants to discuss that with you, so we'll come back to this study.
Okay.
Yeah, go ahead.
Should reimbursement be tied to accreditation? Should be tied to certification and accreditation? Absolutely. If you look at vascular ultrasound right now, there are just too many people doing this who are not qualified to do it. They're getting reimbursed for it, and their results are not standardized ways of reporting or of doing the study. So I think that this should be a must if we're going to consider reimbursement for this. Next. Should IMT accreditation come from a single organization? Well, I separated certification, and this is my definition of it, a method to demonstrate that a person performing and or interpreting the test has a basic knowledge of the proper methods of measurement and interpretation, so to make the technique and its interpretation accurate and reproducible. And accreditation is a laboratory within which one performs this technique meets certain minimum requirements for expertise, accuracy, and reproducibility. Next. So speaking, so my opinion is that certification and accreditation should be from a single provider, not both of those together a single provider, but a single provider for certification and a single provider for accreditation. Look at vascular laboratories. Some, the American College of Radiology certifies them. Others, the ARDMS certifies. This is the most common certification or accreditation, certification body. And in some, neurologists certify. So these are all different criteria, and levels of expertise are different among different societies. Next. I would suggest using an organization that's already involved in this. ARDMS would probably be the best organization. They register vascular technologists, they register physicians in vascular ultrasound. For them to do this, they would have to have a separate category only involving carotid IMT. You shouldn't make someone doing this be able to do all the vascular tests. Or you could have a separate certifying organization and reinvent the whole wheel. Next. And accreditation, I'd be in favor of using something like the Intersocietal Commission for the Accreditation of Vascular Laboratories. They would have to add a 6th category to this. The 5 categories are extracranial carotid, intracranial carotid, renal and mesenteric, peripheral artery, and peripheral venous. The 6th category would be carotid intimal medial wall thickness. And that's it.
Great. So, how do you address this question that Michael Jeff responded very clearly, that you don't have enough registered vascular technician in every lab, and if you're going to adopt a screening, especially you as a primary care physician, you don't have that kind of ability to afford that. So he said an MD, a nurse, practitioner, an office staff who is qualified to be trained could do this if the technique is automated enough. How would you?
Well, I didn't address that because I thought Steve Feinstein was going to talk about this, but I think anybody can be trained to do this technique. It's not just that you have an automatic technique, but the measurement itself has to be done exactly the same way, from the same angle each time. So you need markers to make sure that you're at the same angle, insinuating the carotid artery. And if you're going to use people who don't have ultrasound expertise, then I would insist on distal common carotid artery far wall, because that's the easiest to obtain, and not use internal carotid or the ball.
And how do you comment about ASC's recommendation? American Society of Echocardiography.
What is their recommendation?
As far as
They have a protocol that combines assessment of flag and then IMT of the distal far wall at 3 angles. So you do a short axis scan, you do a flag, and then you do the long axis anterior, middle, and posterior for the bottom of the carotid.
I think that could be discussed.
Yeah, we will circulate that. Again, as a reminder, we will have transcript from this meeting. We circulate it, and our plan is to publish it. So if we miss here, unfortunately we missed Steve Feinstein, some of the key questions about how automated IMT analysis works and whether they're qualified according to a reproducibility that the FDA approves or standardized according to FDA protocols. Any comment, Gene?
Well, I think there's agreement in the field, the automated method just don't work because of the problems with artifact, et cetera.
Okay.
It requires a human being.
Is there any standard FDA protocol?
No.
There is none. And why not?
There is
Well,
exception.
just like any other test, why not?
Well, they give an approval for instrumentation, not necessarily.
Well, that's instrumentation, it's an ultrasound, you can do anything with it, but what about the IMT? Is there not any FDA approval for that?
No.
No, okay.
There's an analysis package approved, it's semi-automated. University of Iowa, they're FDA approved, semi-automated analysis.
So FDA approves software
Yeah.
for.
We also have another one that I know of, that's
No, there's several, yeah, there's not just.
Yeah, there are several companies
There
that
is
provide.
another ultrasound machine that has FDA approval. I don't know about Sonosite, whether you have FDA approval.
Sunsite has an approval of equipment, I believe, and also the software has received FDA clearance, not approval.
Okay, is that, so there is an FDA approval process for that, for carotid IMT ultrasound. Is that right, from the industry?
It's not a protocol.
It's not a
Just
protocol.
approval of the device and the software.
It's not
Clearance, not approval.
What about the automated package? Is that does that come in within that whole category, or does that require a separate approval? Because in
The
my
software
mind-
has to be cleared also by the FDA, not approved, but cleared.
Okay.
All right, let's move on to Tasneem. Is certified vascular technician needed?
Before I answer your question, I just want to clarify to the panel here that I'm a RBT. I have my own ultrasound, my own ISTs. I have an extensive training on IMT, and I know all the pitfalls and the problems that a sonographer can create by doing incorrect measurements. having given that background, the answer to this question I would say is no. Should MDs, PAs, NPs, and other qualified medical practitioners be allowed to do the test? Be allowed to do the test? Yes, but there will be the big caveat, which I think has been addressed very nicely before me, about understanding the pitfalls of the technique, the sensitivity, the resolution needed to do the test, and therefore that brings you to the importance of training. If you are going to have non-sonographers do the study, then these people will really have to be given training. And what is the minimum training? I think the important thing is for them to know what IMT is, to understand how one can put somebody in 50th centile versus 75th centile, but just a slight increase in some millimeter dimensions. So that requires theoretical, they need to understand what IMT is, lectures and
So they can be trained. What do you think the training time would be?
Okay, so-
I'm MD, okay, so
Right,
you
right.
went and became I'm MD. How much time do I need to allocate to be qualified for this?
So not every MD knows what IMT is, and I think that, therefore means that everybody needs to be trained on all the studies done in IMT and the background of this, which I think is a minimum of, you're asking me in terms of days, right?
Right, like a week or
Well, for an MD, I would think a 1 day of background theory, and then as far as the practical training of how to do an IMT, how about if I had to train Dr. Fuster how to do an IMT?
well, he will just use his 3D ultrasound
Right,
and
he's
press a button.
He seems to be a big fan of it. I would actually, the person has to understand the instrumentation, the basic fundamental principle of ultrasound, before you even touch any patient or subject or volunteer. You then need to understand the anatomy of the carotids, the variability associated with the high bulk bifurcation, low bifurcation, and all the others. And then you need to basically start training, the demonstration of how to do an ultrasound on a patient to somebody who's learning, and then to actually do hands-on learning with that person under guidance of the person who's qualified.
Just like an exam, they take the test.
Right, because there are these fine nuances. You can tilt the transducer upward, downward, forward, lateral, and that can produce a difference. And I think, as you said, if you choose 3, and I actually like ASE protocol. I think it's simple enough, and it is simple but yet comprehensive enough in that it would probably not miss significant disease. So they recommend doing a short axis scan from the base of the neck all the way up. So you would actually pick up, you kind of get a 3D type of an image of the artery. You're seeing the entire artery in a circle, although it's not pristine circle all the way, it's easy to say. So you actually identify if there's any major plaque, and if so, where is it located? Because these are usually eccentric.
But there is a study, by the way, published looking at
Exactly.
training people to
It's
measure
called
fibrin.
Opaka study. It was actually published in.
Yeah, I was an author, Jim Stein's the first author.
Okay.
Right.
So do you have any bottom line of that study?
People can be trained to do it.
Community training to do it. Okay.
Does that study have total variability? What I've seen is the reader variability, but I've not seen the total
I think
variability.
it did report total variability. They actually, I think, even compared images to a standard ultrasound equipment, and they found that the differences were very insignificant. And I don't know the exact numbers, but I think in their hands, it appeared that the variability was not much.
You're talking about performance-based training and certification, not a multiple choice test, right? Like sonographers currently undergo an ICAVL or.
Right.
Performing and looking at coefficient of variation after the study, et cetera.
Right.
Other people-
But in my
The
opinion,
test is multiple choice, but to be able to sit for the test, you actually have to do things beforehand. You have to perform many studies before you're allowed to sit for that examination.
Okay.
But there's no
So-
quantitative estimate of variability. Or is there?
There wasn't one.
For an examination, I'm talking about a certified examination.
For like
Yeah.
Artemis or ICAVL.
Right.
Right.
You actually have to do the studies, lots and lots of the studies
right,
before
I
you
think
can sit.
that is a fundamental problem, and that's the activities lead of the training, is once these people have had their practical training course, let's say a 2-day course, they then have to go back and do the studies and submit their studies to a certifying body, which looks at their results and then approves them once they meet certain standards.
Okay.
And I think that's the minimum amount of training
That's what we need to address. What is the details? But I think what the conclusion of the panel is there is a significant problem or issue coming from source of variability coming from operator. either manual operating test as well as manual interpretation of the test. And we will go into more details. In the interest of time, we have 2 more presentations.
Can I just make one quick, a comment was just made that I think what people do is they go to different ultrasound booths in the national meeting, then they have somebody do their IMT, and then and then they go to the next booth. And you know the problem more is that you can't ask for a test to perform, you know, exquisitely in a booth.
In a booth, that's right. That is.
And I think the biggest problem with this measurement is you know, yes, sonographer, yes, angle, but I think those can all be dealt with. My problem is the automated measurement. If you don't have a very sophisticated and a very precise tracking tool, you can actually over or underestimate IMT very easily. So I think it's unfair to say that your IMT changes. Yes, it's going to change from booth to booth.
I take your, from booth to booth variability, I take that, well, I did actually myself and went from 0.4 to all the way 0.9. And I just released my medical information. Okay, let's go forward with the actual presentation that we wanted to get from Dr. Fuster, guiding us as far as whether we need national coalition and some comments about HRP, and then hear from Erling about the association between carotid and coronary trauma. I think we have a little issue over there. So do you want to yeah, go with this one? Increase the size of it.
Well, the question that I was asked to address has to be seen within the context of a few things I want to say. First of all, Institute of Medicine, in a week from now, is coming out with a document, which is how to prevent cardiovascular disease worldwide. And actually, I was the chair, and it has been a work of a whole year, almost on a weekly basis in Washington. And I have to really address your question in the concept of there. Now, this committee evolved with the 3 following principles. First, there is no knowledge of what is going on, epidemiologically and economically. Second, there is a lack of responsibility in addressing the issue by everybody who was supposed to. And third, do we have to incentivize people to do the job? This was the principle by which the committee actually evolved. I cannot even say a single word of what the final conclusions are for obvious reasons, but I can certainly say a few things that are observations. Are 4 issues. One, you all know that this is a global epidemic of cardiovascular disease, but there is an economic burden, but there's a huge confusion here. Confusion number 1 is that there is a lower incidence of the disease in terms of age adjusted. That his life has been prolonged 6 years in 3 decades. And actually 4 to 75% is due to treatment, not due to prevention. So is the disease is decreasing? Here comes the paradox. In fact, the prevalence is increasing. Why? More population get in an older age. We don't allow them to die. And the risk factor profile is still around. So what we are seeing is age-adjusted decrease, but the disease is increasing in prevalence. So, and I have to come to the economics of this in a moment. That's the first issue. The second issue is there's a significant gap between the knowledge of what we are talking about and the action at all sectors. The third, and this is actually very troublesome, there is no quantification of information available today by which we could use a gold standard from anywhere and move forward. Everything has been done descriptively, but not quantified. And I think this is a critical issue which leads to the next point, what to do. And there's an urgent need for intersectorial approaches, government, health system, and so forth. If this is not done, the sense is that things are not going to work. Because at individual basis, many things have been done, but the prevalence of disease is increasing. So there's something wrong with the whole system. And this should be done at the national and subnational levels. And here comes the issue. There are 3 aspects. One, promoting health. Salt restriction, tobacco regulation, physical activity. This has to be done at a very high level. And although it appears to be stupid, we would decrease 50% of the events by just doing this at the government level like they did in Finland. I think this is very important to really get into this. The second issue is the primary prevention. And this needs regional research and quantifiable data. In other words, the sense is we need demonstration projects. What you cannot do and will not work is to go across the country and set up rules and regulations. It will not work. And I have data from the HRP which will support that. You know, what you can do is to go with SHAPE, look at Texas, wherever you look, see what the data is in 3 or 4 years, and if it works, then you can go to the neighborhood. But to try to make a national guideline is just impossible because you need the backup of lots of institutions which in general they have not been able to do it because of a turf. Each one wants to lead it. I will tell you this in a moment. And finally, secondary prevention should also be done at the regional level, and this is all research. So in fact, if you're asking my opinion about SHAPE, it's a research project. You might not like it, but that's what it is. You're trying to figure out what do you get from there, and see if your hypothesis is correct. Then nobody knows. We're talking about intimomedial thickening, and look at the discussion. In other words, I think this is very important. So I think SHAPE has a reason to be, but I would be very much against to go into all over the place because it's going to crash for obvious reasons, because you need data, you need to be convincing, and that's all. So let me now go into the statement number 1 in the last one, which have some wording. The burden of disease, and this is the paradox. What is basically happening is the incidence of disease is decreasing, that is, life is being prolonged, but the prevalence is increasing, mainly because of treatment, which is, I can tell you the dollars because there were 7 economists out of the 15 people in the committee. So this is not a joke. It's an economic level of tremendous degree what is happening. In other words, just to tell you that in 10 years in this country, the budget for treatment of cardiovascular disease has multiplied by 3. In 10 years. From $100 billion to 300. So this is the reality.
Right. But when we say this incidence is decreasing, but is it decreasing?
No,
to
no,
the
the
level
mortality,
that you're comfortable?
no, pardon, I didn't use the right word. It's the mortality is decreasing by age. In other words, there are less people dying at age 50 today than 3 decades ago. So life has been prolonged 6 years. And people call this mortality incidence, but this is age adjusted. This is correct.
Right.
But you pay a huge price, and that is the treatment is very expensive, and the prevalence is going up. So how do you stop that? And this is really the dilemma that I want to present. Now comes the other issue is what do you do? So we are really moving into what you call like SHAPE, demonstration projects, and that is what are hypotheses of work that if they are correct may change society where we live. This is really the issue. And now I'm getting out of the government, I'm not going to go into all of these. These are the 6 we are involved, but I'd like to touch a base on the HRP for a moment, which was your question. You know, this is a mobile unit that almost 7,000 people enter into this unit. There were 18, and this was done in Chicago and in Florida. People were over age of 55, and interestingly, 70% of the population had at least 2 more risk factors in the population of Chicago, which to me was amazing. In other words, we are really dealing with a sick country when you really look in detail. We went to Florida, and it's about 50% of the population over age of 55 has at least 2 risk factors. It's less than the population of Chicago. So you are already dealing with a very high-risk population to start with. And then we use different technologies, and this is the 3D ultrasound that I mentioned, calcification of the coronaries, AB differences, and then ultrasound of the abdominal aorta. And then if we go into more sophisticated technology, but I'd like to present this because I think it gives the concept. When we look at data of the 3D, which is 1 millimeter or more in focal disease, and you go, for example, women at age 65, it's amazing that almost 50% have bilateral plaques, and actually close to 80% have plaque in one of the carotid arteries, which is what I was saying before. And this is real focal plaque. Now, having said that, then you do positron emission tomography, and you can actually find the whole artery disease. It's not just a focal point, which is the point you're trying to make
Yeah.
before. Then you begin to get into the regional disease. The data is beginning to evolve, and I was allowed to present these actually, which is we are already, what we do with the study is a surrogate endpoint that goes into a 3-year follow-up to see if the burden of disease with all these techniques predicting events. That's the key of the study. And we already had, I think it was about 20 strokes. From these, 16 had bilateral carotid disease. 1 had unilateral, and 3 didn't have disease.
At all, disease meaning according to your 3D,
According to-
even your 3D.
Just
did not-
only the 3D.
And your 3D did not find anything in these people who had, 3 people who had a stroke?
Yeah.
Out of,
Okay, but the question is what is the cause of the stroke, not necessarily carotid disease.
Right.
To show that we are not.
Right.
So, but the point is, there's a lot of predictability though. You cannot use a statistic with these numbers, but this is really happening. And then when you go into the coronary arteries, this has to be tabulated, but the point is, there is already a trend showing that when you have bilateral disease, the score of calcification is much higher. So, and we could go into the legs and so forth. I want to conclude, this is actually a new machine that we have, which is PET MR, and then we'll have CT2, all in a single machine, but this is all research. The point I'm trying to make is, and I think Erling is in agreement with, this is a diffuse disease, absolutely diffuse. And the question is, where you capture it first, you can already tell what Framingham just showed. That at 10 years, 25% of people with 2 risk factors may have a stroke. But if you follow for 30 years, 75% have it. So I think we have to look at the risk factors quite differently. And that is, if you give your life 30 years span, is much of a problem if you have risk factors that if you just stay on the 10-year deal, which has been always a debate, 75% will not happen to me. This is a huge issue, and the imaging supports that.
And it would be even more if you shorten the time period. If you're looking at the definition, what we're interested, for example, in the vulnerable patient discussion, then you're looking at changing behavior in the next 2-3 years or 5 years. In that time period, the risk factors will become even less and less predictive because, as you said, their lifetime predictive value is good. But in the short term, and we should know that people really don't change behavior, I mean, psychologically, based on lifetime. It is something that you tell them if something is going to happen.
I'm not sure. Let me tell you preliminary data here. Okay, these scans were shown to about 500 patients. Your arteries are plaqued up. Okay, let me tell you, we don't have these now, but we just have been discussing. And the problem is a drama in the first month. After a month, this is a matter of the doctors and of the scientists who is over. And then, unless the doctor becomes obsessive, this goes away. And this explains the Eurospire data in Europe, where patients with myocardial infarction, only 50% are using the 3 drugs they are supposed to use after the infarct in a year of follow-up. So we are in a society in which we constantly reject the concept, if we feel well, then we are in trouble. Therefore, you can screen anybody you want, but the problem you still face is how, unless you have a system that is able to incentivize people and to do something, you end up halfway. And this is actually one of the things that we are beginning to find out, very deceptive, but really comes from many other studies which directly and indirectly show the same thing, that we tend to reject the situation if we feel well.
Well, I think you're referring to the same thing. After a year, they forgot. Their memory span is, 6 months. And so if we have a way...
is after a month.
Is that after a month? So we have a major issue here with the compliance.
That's not true. There are several coronary counseling studies which show increased compliance, increased prescription of statins and aspirin, and duration of compliance with therapy after seeing the counseling.
Yeah, maybe this is different. Here comes the issue, I can tell you, who you select for the classification. And you start with a select with a population, many of them are obsessive. This is not. This is really going to an overall population of humana in which there is no such a thing of selectivity. And I think this is a critical issue. We all have our patients who come to us and they want every test being done. That's not what I'm talking about. What I'm really talking is, actually we did the demographics of the Chicago area, and we really got the people, demographically speaking, were not different than the general population, economically speaking. So it's the way you enter the patient into these studies. You might have what you say, you might not. My point of view after reviewing all of this is actually rather pessimistic in terms of how the society reacts to all of these. This is all that I can tell you.
A general comment. I think we would agree that there are all these problems and you're projecting a 10-year interval in which to answer them, right?
Yeah.
But we have a problem right now, and we have tools like coronary calcium and IMT, which can identify high-risk patients. So
I go along with you. This is why we are doing this, but I want to point out it's a demonstration project. It's a research project. It's not you are going to convince the United States population that you have to go all over the country doing IMT because it's not going to happen.
Well, on the other side, we have USPTF task force, which sits here and refer to it. The latest publication was 2004 or 5, and they're defining our national health care. I mean, this is unbelievable.
Well, I agree with you, and we have to push it.
Yeah,
and
we
this is why
have
I'm
to push
sitting
it.
here.
Yeah,
But
we have
I
to.
want to be very realistic, and that is we need to know the parameters. We need to know the parameters we are dealing with, because otherwise you can be ballistic into one.
We have to create the evidence. You're the first to create this with HRP trial. And if HRP comes out in a year or 2 years with strong evidence, then there would be a big push.
You need to create the science.
And
no
we're
question.
trying to do the same thing instead of Texas, putting monitoring tool after 2 years of implementation of this bill. What will happen
This is what is lacking.
That's what we're going to do. No,
Absolutely.
that's exactly what we're trying to do in the state of Texas, to put monitoring tool, both at the economical level as well as the number of people, and what happened after that, so we can show the national level and do it.
You know, I
Let's go.
think one more comment. I actually think you have to figure out which population you have to treat. Because I looked at the Texas law, that was part of my talk, which I won't be giving because of time. They included diabetic patients in there, which is stupid. Oh, this is my wife. Sorry, I'll get this in a second. I think diabetic patients don't need to be screened. They need maximal medical therapy.
Well, I wish
I
Dan was
disagree
here.
with that.
I wish
Disagree.
Dan
Well,
was here, Dan.
That's fine, but you know, there's no organization that currently doesn't suggest that patients with diabetes are not at coronary heart disease risk
But
equivalency.
they're not, and that's based on populations. 40% of patients in Mason had a 0 score that were diabetic. So if you don't have access to good tools, then you use the population.
Yeah, but
Josh,
if you're
I think the
practicing, but no, what I'm trying to say is where what we're doing needs to fit in is here. We already know who needs treatment, right? The risk of the group of people that will currently be given drugs are those who are at intermediate risk and have some other thing that puts them above, right? So the best one the one that's moved the farthest so far is CRP. And they've done a trial where, we're not talking about screening, but if you had a CRP above 2 and you were in the right age group and you were treated, then your event rate went from 1.35% per year down to 0.77% per year. So now, since that is the first one out of the barn, the tests that are being talked about today need to show us that if you have a CRP under 2, and you're at intermediate risk, so FRS under 20, and your LDL is under 160, then you would have some benefit from being treated with a statin. And that is what has to be done so that you get sign off from everybody that it's obvious and should be done. But at this point, there is no evidence to suggest that you can, in an unselected population at intermediate risk of all comers, do the test and then treat them and then see that there are good outcomes. And if you want to convince someone like me that I should send someone for a coronary calcium score, then you have to show me that in an unselected intermediate risk population who I just described, they get benefit from treatment.
just to present the opposite point of view, I think if you did that trial and showed that they did not benefit from treatment, it would be the fault of the treatment, which is not to say that you shouldn't identify those who were at high risk. If we can't improve their outcomes, we're doing something wrong with the treatment. And to not identify these patients is a form of therapeutic nihilism.
So I think what you, Josh, this is your last slide, right?
Yeah.
So this is what your point is. That I think we'll come back to what you initially brought up, and that is, do we give aggressive treatment, and do we give maximum treatment at the beginning? There has been several opposing, views that we don't, and we need to be able to titrate our therapy.
Yeah, but it's the same thing where we think it's going to work. But look, when we tried to lower blood pressure to lower than 120, it didn't work. We know that when we added ferulic acid derivatives to diabetics above statins, it didn't work. And so the idea that you can intensify therapy and make people better is as much a supposition as that you can do screening and identify people who need treatment and will benefit from it within that spectrum.
Okay, so as a follow-up to that question, do you have programs in place, and as Dr. Fuster pointed out very rightly, that let's just do this experiment in Texas, show that a screening does make a difference in outcome. What do you have in place to actually make that happen before this thing can be?
Yeah, we're trying to build another statewide legislation, or not legislation, support to do monitoring at the state level. Basically, this bill will be adopted, but we have some issues in the adoption, and that is who does the test and where the test is reimbursed. Our goal is not just to provide this opportunity for increasing income at 5 or 10 or 30 big hospitals. That's not going to make a difference in the primary prevention. We want to be able to have that in the doctor's office, in the primary care physician's office, and that's where some of the issues that you're facing this. But beyond that, if we address that, which is being addressed by Texas Department of Insurance and ICABEL, and we'll be working with them as well through SHAPE, we will be implementing monitoring. So in a year, 2 years, we'll look back and see how we've done, and that's really the best marker to go and talk with the national societies and so on. I'd like to terminate our meeting with Erling's slides. Erling is pathologist, so he brings a significant amount of insight from a pathologist point of view. What's the connection between carotid and coronary? And yeah, you can sit here.
I will only show a few slides because of the time, so I'll just skip all these to get into and tell you a little bit. We studied atherosclerosis at autopsy and made a comprehensive study in 100 autopsies to see if it was the same disease we saw in different vascular territory. And we examined the carotid arteries, we examined the coronary arteries, and we examined the femoral arteries. And as said, there was 100 autopsies, and we selected atherosclerosis susceptible parts of these arteries, the proximal part of the left anterior right coronary, the carotid, and the superficial femoral arteries. And it was a section we took out 48 sections from 100 autopsies. And we used the classification from the American Heart. I will not go through it. Just 1, 2 is early lesion, 3 intermediate lesion, and more than 4 is plaque. And in fact, about this disease, we know it's a systemic disease. We know it's a generalized disease, and it's a multifocal disease, but in fact, it's not a diffuse disease. And many people use this term interchangeable, diffuse, systemic, generalized, but in fact, it's not diffuse, it's plaque, it's multifocal.
Is it a systemic disease or not?
It's a systemic disease.
It's a systemic disease, but
it's not diffuse. It's not diffuse.
Focal manifestation.
It's
multifocal manifestation.
Yes, it's
okay.
focal and it's focal manifestation.
Okay.
So it's multifocal disease. And here we found by measuring the plaque burden in this different vascular territory, there was a close correlation between plaque burden in the 2 coronary arteries, in the 2 carotid arteries, in the 2 femoral arteries, right and left, but also a close correlation between plaque burden in the coronary carotid, in the coronary femoral, in the carotid and femoral arteries. So the amount of disease correlated closely in different vascular territory. And here we have the
Sorry, could you go back to this? That's fascinating. So the carotid and femoral and carotid and coronary have almost the same correlation as LAD and RCA?
Yeah.
That's fascinating.
Yeah, but it's the data.
That's fascinating.
That's not REMT, right? That's plaque.
That's
I come back to
disease.
that. It's plaque.
Right.
It's plaque.
Right.
It's type 4 or higher, according to the American Heart Association. So it's what we have here. It's plaque, how it was distributed in the different vascular territory. White is normal, blue, or what it is normal, and the green, it's plaque. And we can see there's more plaque in the coronary than in the carotid, and least plaque in the femoral artery. And we know that. So in fact, we have plaque here in the coronary, and we have not so much plaque in the femoral artery. We published that, and we focused, in fact, on that atherosclerosis develops slower in the superficial femoral artery than in the coronary artery. So if you have plaque in the femoral artery, you will always have plaque in the coronary. So plaque in the femoral artery is a very sensitive, very specific marker of coronary artery disease, but not very sensitive. And it's the reason it's useful in older people, but not in younger people. If you have a low ABI, you do have plaque in your coronary artery. So it's the target for using this difference imaging tool. So as in ABI, it's useful, of course, in older people, not younger people. Then we classify the type of plaque in these lesions, and we can see the plaque in the coronary and carotid, they contain, many of these plaque contains necrotic core. And we know it's what characterized high-risk plaque. And there was not so many plaque in the femoral artery with necrotic core, they were more fibrotic. So, and if you go to the carotid, and I will come back to that because I think it's very important to understand what we see by imaging, there's a lot of foam cells in the carotid arteries. Foam cells is macrophages that has taken up lipid. So we examined the carotid in the different segments, the common carotid artery, the carotid bifurcation, the bulk, and the internal carotid artery, to see how the disease differed along the carotid artery. And we found here that in the common carotid artery, where we measure internal medial thickness, most of them contain the lesion we see here. Either it is a normal artery or it's foam cells. There's very little plaque in the common carotid artery where we measure common carotid artery internal medial thickness. Going to the carotid bifurcation and the bulk, we have a lot of plaque, and many of these plaque contain necrotic core. And going into the internal carotid artery, there's not so much disease. And here we have two carotid arteries open longitudinally, and we have the bifurcation up here. It's plaque. It's the lesion causing stroke. And we have the common carotid artery here. It's where we measure internal medial thickness. There's no plaque, or very little plaque. But there is disease, vessel wall. I think it's another disease. We can also see here atherosclerosis is a focal disease. It's a lesion at the outer wall of the carotid bifurcation. And when you come down to the common carotid artery, there is not much focal disease. There is a diffuse disease. But I don't think it's the same disease. It shares some common feature with atherosclerosis, but I don't think it's the same disease. Here, in fact, we have the internal carotid artery, and it looks very much what you see in the common carotid artery. And look at it, and I think we can understand many things what we are doing by measuring by carotid ultrasound, and in fact also with fluid deoxyglucose by PET-CT. Because we can see here we have media, it's what we measure the intermediate thickness. The thickness of media, it depends on hypertension. So it's correlated with hypertension. We have a foam cell lesion here, a lot of foam cells. We know that these foam cells is the first cells that appear, it's also the first that disappear when we induce lesion, and when we